Another thing to consider in our scene size up, is this a violent or potentially violent situation? Is this a civil disturbance? Did somebody just, rob a bank? Is it a domestic dispute? Are husband and wife or, a couple of some sort fighting? Is it a crime scene? Is there a large gathering? So this one's actually the thing I am most scared of myself, because you have so many people that can get involved, and it can turn into a really big situation really fast with large gatherings. So these are situations you would probably consider calling law enforcement. So call law enforcement, LE, law enforcement. Another place to be concerned or to be a little bit more aware of your surroundings and your patient is in behavioral emergencies. So patients who have things like bipolar, schizophrenia, or any number of other mental health related issues. Not all of these patients are going to be violent, but they do have an increased potential to be violent without cause. So it could be that you walk up and something that they see in you triggers a memory, and then off they go. They're talking crazy and they're throwing punches and they're coming at you, and it doesn't have anything to do really with you. It has to do with their mental health issue. So determinants of violence in these patients, if they have a past history of it, look at their posture. Look at their hands. Are their hands balled up in a fist? Do they have just an angry stance? Are they eyeing you down? Do they, if you move a little bit, do they keep tracking you with their eyes? What's their vocal activity? Are they quiet and calm, or are they really loud? Are they gritting their teeth? They just seem angry. And what's their physical activity? Is it lots of motion, or are they still? If they're moving around a lot, I'd certainly be more concerned that they're likely to throw a punch. Watch their hands, watch their feet, watch their friends if they have people around them. Make sure that you pay attention to all of those things to help keep yourself safe. Your personal safety is of the utmost importance. You have to understand the risks of each environment you enter. And part of that is knowing that we don't know all the risks of the environments we enter. That's part of the understanding here, is that we don't know all of the risks. So we have to be prepared basically for anything. So we've done our scene size up. The key components here, BSI, scene safety. One of the things we didn't really, we mentioned, but I'm going to put up here is number of patients. Do I need additional resources? I'm going to look at the mechanism of injury or the nature of illness. So basically what's going on. I'm going to write this out so you can see it. And I abbreviate this MOI, NOI. And then one of the last things you're going to kind of consider as you're moving into your primary assessment is, do I need to immobilize my patient because they have a potential spinal injury? So spinal motion restriction, SMR. So let's move into the primary assessment. So what is the primary assessment? Well, the purpose here is to rapidly identify and correct life threats. Know and understand this. The purpose of the primary assessment is to rapidly ID and correct life threats. We also want to identify those patients who need rapid evacuation and transport. And the goal with these patients is minimum time on scene and maximum care en route. So these are the ones we call load and go. And then we're going to assess airway, breathing, circulation, disability, and exposure. So let's move into our primary survey. So the first step is our general impression. So this is step one, general impression. What does the patient look like? So when you're doing a scenario, come in and say, hey, what's my general impression? I also like to call this your view from the door. So you walk into a patient's house, and before you get there, you can look at the patient and go, oh, they're sitting awake, they're talking to me, they're not all that sick. I mean, I'm not so scared I don't have to go take immediate intervention. You know, they're talking to me. Or you walk in, your patient looks blue. They're gasping for breath. They're really sleepy. They're falling over. You see that, and you know that your patient is really unstable. So the goal here is, this says stable, potentially unstable, or unstable. I like sick, not sick. Are they sick or not sick? And this can change, right? Your primary impression can be not sick, and then you can kind of find out later, oh, maybe they are kind of sick. They're not like dying in front of me, but they definitely need some medical treatment and some medical intervention. So your initial decision here is, with the general impression, is sick, not sick. Are they sick or are they not sick? We also at this point are going to assess level of consciousness. So this is also really something we can do from the door. We measure level of consciousness using the AVPU scale. A stands for alert. This means that they are wide awake, they are looking at you, they make eye contact with you when you come in. V is for verbal. And someone's level of consciousness would be verbal if you have to kind of call their name to get their attention, if they're kind of asleep and you say, hey bud, wake up, and then they wake up. That's all you have to do is basically call to them, and then they'll look at you and interact with you. Or they'll moan at you, but you don't have to touch them. P stands for pain. So it may be that some patients are really out of it. Maybe somebody has overdosed on a pain medication, for example, and it's made them really sleepy. You yell at them, hey bud, it's not working, they're not responding to you. So you go over, and the trick you use, hopefully you guys have a pen in your hand. I want you to take that pen and put it on top of one of your nail beds on your index finger and kind of roll that pen back and forth really gently, but enough to recognize that it kind of hurts. And if you push a little bit harder, it's going to really be uncomfortable. And it's going to be uncomfortable enough that it may cause your patient to respond. Patients who respond to painful stimuli may not always wake up. They may just kind of withdraw, so they may kind of try to pull their finger back, like pull their hand back. They may moan. They may try and push you away. Whatever it is they do, you know, make a note of their reaction. And then U is unresponsive. Oops, UN, responsive. So a patient who's unresponsive, you know, they're not looking at you. You yelled, hey bud, you pinched their nail beds and still nothing. That is how they get the U designation, the unresponsive designation.